I bent over to run the Johnny mop around the inside of the toilet and dip my necktie in the toilet. And she just had the biggest laugh at that. But she was training every new person, coming through the training program. And what a great lady.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Darrel Hicks, owner, principal of Safe, Clean, and Disinfected Environmental Services. And that's exactly what we're going to be talking about today with Darrel, is environmental services. And really, we've learned what a critical and crucial role environmental services play in infection control, infection prevention, not only in the healthcare environment, but really in the general public settings as well. We're talking restaurants, hotels, schools. That's right, Larry.
Gymnasiums.
Any stadiums where you go to see a concert or a game. I mean, this is really front and center, and I think it's only beginning to gain momentum. And I promise you, this is going to be a longer interview, but you will be disappointed if you don't stay until the end, because Darrel has a story that is going to place the level of importance of environmental services squarely in the center of your conversations as you move forward, not only maybe in your healthcare career, but just as you go through daily life in the general community.
Yeah, I've not known much about environmental services in the healthcare setting. It's not something I've done much research on, so don't know much about it, but I'm very interested in hearing what Darrel have to say about it, what he can shed light on. My understanding is infection prevention and public health, one could argue, starts at environmental services. That is the point. The cleaning of the surfaces, even cleaning of your hands. We've been taught that our entire life. So I'm interested to see how environmental services, which is really public health, how we can talk about that and hear Darrel's story.
Well, let's get right into it, because I don't want to keep the audience waiting any longer. We'll be right back after a short break with Darrel Hicks. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Darrel Hicks, owner and principal of Safe, Clean, and Disinfected Environmental Services. And Darrel, I'm really excited to talk to you today. We've had so many good interviews recently, but to really dive in on environmental services, which the audience will hear us refer to as EVS throughout this conversation today, but really we're talking healthcare environmental services. And you're an expert. You've written a book on it. We're going to talk about that as we go through this interview, but thanks so much for coming on.
Thank you, Justin. It's a great opportunity, and I'm always anxious to tell the environmental services story, because I think it's one of those foundational services in the hospitals and medical facilities, and people's lives are depending on how well we perform our job. I believe we're on the front line of infection prevention, and so it's a message that we need to share with the world.
And so, Darrel, we recently spoke to an infection prevention professional, and a lot of these kinds of conversations were coming up, and I think it has a lot to do with what's been going on in the world the last 18 months. I think just people's focus on infection and infection control, infection prevention has really risen awareness, not just in healthcare, but really in the general public as well. And so why don't you tell us a little bit about your background and how you even got interested in environmental services to begin with?
Well, I go all the way back to 1981. At the time, a fellow from our church recruited me into a company called Service Master, and it was a company that offers hospital contract services. They had maintenance, dietary, housekeeping, or environmental services. And so I got recruited into that. And part of the reason for that was that, the company's 4 pillars was, first of all, to serve God in all that we do. Secondly, was to help people grow and develop. Third is to be good stewards of the resources that we have. And the last one is to grow financially. So with those 4 pillars, I felt like I was in the service business. And as it turns out, I was wishing to be an English teacher at some time. So I was getting into education, and my career took a turn at that point. I was in my early 30s, and I got married right out of high school. So we were, it was a transitional time for me, but I was glad that I took the job, and I stayed in it for 34 years and just retired at the end of 2014. But, I stay engaged because I feel like there's a message that I have that needs to get out there, and that is that clean surfaces save lives. That's why I'm still engaged, and I'm grateful for this opportunity to talk with you.
Yeah, I mean, this is literally a labor of love for you, quite clearly. And something you said about clean surfaces save lives, I mean, that's really important. I'm not sure that everybody always necessarily agrees or resonates with that. And I think that's why your background, or at least your intent to be a teacher and an educator, and the training and all of that went into that must have become integral to, your success in serving, those 4 pillars and really your life's mission that way.
It was, and environmental services department, probably 80 to 85% of your budget is labor. So it's a very labor intensive department. So when 85% is labor, that means people, human resources. And so Service Master's way of training us to be leaders in that department was we had to do every one of those jobs ourselves. And I learned, it was the first day, and I was working with an elderly lady, and she was showing me how to clean patient rooms. And she, we were expected to wear a shirt and tie and suit and all this. So here I am in the room, and she's telling me how to clean the toilet. I bent over to run the Johnny mop around the inside of the toilet and dip my necktie in the toilet. And she just had the biggest laugh at that. But she was, training every new person, coming through the training program. And what a great lady, and very patient focused. And this was back, like I said, 1981. But, I had to learn to shampoo carpets, refinish floors. And the reason is that I would never ask someone to do a job that I didn't know how to do myself, or I wouldn't do myself. And so, what I would tell guys that say, you can't buff a floor, I said, I wasn't born in this shirt and tie. I grew up working hard, and I can do it. Maybe not as fast or as well as you do, but I can do it.
Well, and I love that servant leadership perspective, because if you're going to provide any kind of leadership, you really ought to know, the ins and outs of the job. And so I think maybe even as we set the table further for this conversation, tell me about, what do we mean when we say environmental services worker? Like, who are we typically talking about? What's their pay scale like? What are their work conditions like? Like, paint that picture.
Well, in today's world, I read today where hotels are going to have to cut back on the services that they provide for guests in the hotels because of this labor shortage that we have going on. And I go to restaurants, and, where they normally open up at, 6 o'clock in the morning, now they're not opening until noon because they don't have the workers. So, we're talking about competing for this pool of people, and a lot of them are unskilled. I'm not saying they're uneducated, because they're very intelligent people, but they have no other skills other than cleaning. So I would rather take a person who knows nothing about cleaning, as long as they have that good interpersonal relationship, because, they do have to interface with the patients and their guests in the room as they go in every day and spend 15 to 20 minutes, servicing that room and doing their task. They're expected to engage with the people in the room. And a lot of times the patients will remember that housekeeper, and because she talked to them. And so it's, they're expected to engage guests in the hospital. And I think, a long time ago, we turned a corner when, we stopped calling them patients and we started calling them customers, because I think customer has kind of a financial ring to it. And when they're patients and guests, it's different than a dollar sign. We expect people to be genuine and go about their job. And then when they're done, say, did I miss anything? And so we taught people to say, did I miss anything? Because if they've been laying there and looking at this blood spot on the wall, and if you got done cleaning the room and said, well, I'm done, I'll see you tomorrow, they would say to themselves or to their daughter sitting in the chair, she didn't clean the room again today because the spot's still on the wall. So if we ask, is there anything I missed, and then take care of that for them, then the room will be clean. And a clean room is one of the three things that patients will remember about their stay. One is how good or bad the food was, whether nurses really took care of them, and whether the place was clean or dirty. And people are pretty good judges of clean. And so, it's the appearance of clean, and that is one level, but then microbially clean is something else.
So, Darrel, when I was reading a little bit about your Infection Prevention for Dummies book, I noticed that you talked about how it was important for managers and staff responsible for cleaning a school, for example, or an office building or a medical facility, how important this element and this practice is. And I want to talk about that in the context of COVID in a little while, because that became a very kind of controversial and complex topic to talk about that I think you can explain some important facets and aspects of that to me. But before we do, you had talked earlier about clean surfaces save lives, and sometimes I can get confused about which specific pathogens or superbugs or viruses, for example, a coronavirus or not, C. diff, what specific type of pathogens should our listeners be focusing on that when they're cleaning and protecting the patients through this important practice, what organisms or pathogens are we really talking about that we get a sense really can be transmitted by the environment, as opposed to maybe that can't be? And then that'll lead into a follow-up question I had for you about COVID. But can you fill us in a little bit on the VREs, the C. diffs? What exactly are we concerned about the environment infecting or at least exposing our patients to?
Well, there's a hierarchy. So you've got the low-level pathogens, and these are bacteria mainly, and they're enveloped viruses, enveloped bacteria. Coronavirus, COVID-19, is an enveloped virus. And so that means it's very bottom, easiest to kill on the scale. And the peak of the scale would be something like C. diff. That is a spore-forming, kind of a hard outer shell, and it's like a plastic water bottle. You can't get to the water inside for the plastic on the outside. So there are certain disinfectants that will break through that hard outer shell of spores. So if you have that disinfectant, then it kills not only that spore, but everything all the way down to the very bottom of the scale. So it is the hardest to kill all the way down to the easiest to kill. So if you have a sporicide disinfectant, then it kills not only spores, but all the way down to the bottom. And so it doesn't matter whether it's gram-positive, gram-negative, envelope, non-envelope, virus, bacteria. The thing about disinfectants is they're not like antibiotics. Antibiotics can only be given for bacterial infections, and there are some virucides, virucidal sort of
low-level disinfectants, for example, that have label claims for the destruction of HIV or the hepatitis C viruses, for example,
right.
that you're talking about.
Exactly. And so an antibiotic is like a key to a lock. And that's why when penicillin was first used for an injectable and saved so many lives in World War II because of being able to stop infections that killed a lot of soldiers in World War I and all the way back to the Civil War, if they just got a bullet wound that could fester and turn into an infection that killed them. So World War II, when penicillin was injectable, it saved so many lives. Well, Fleming, who found this injectable penicillin, discovered it, he predicted that within 2 to 3 years that these bacteria would morph and adapt to the penicillin, and you don't hear about penicillin being prescribed anymore because it was a lock and a key, and penicillin unlocked that lock, but no longer is it doing that, so the key is gone. So with each antibiotic, whether it's methicillin or vancomycin, which are kind of the end of the line, and there are no new real antibiotics being developed by pharmaceutical companies because by the time it goes through the whole approval process, the bacteria has changed and morphed. And so they're putting their R&D into things you're going to take for the rest of your life to lower your cholesterol or to manage your kidney problems. So, but a disinfectant is like a sledgehammer to that lock. It's 100 times stronger than the antibiotic that a doctor could prescribe for you. If you took antibiotics at the strength of disinfectants, then it would be so toxic it would probably kill the patient. So because we have these disinfectants, some of these legacy disinfectants have been used for 100 years, like phenolics. They've been around for a long time, and there's no disinfectant-resistant organisms that I'm aware of. And so it's a different dynamic when you're talking about disinfectants as opposed to antibiotics.
Well, I'll tell you, there's a couple of things that you said there that are really important themes for why this conversation is so important today. And we are going to talk about antibiotic resistance a little bit later in the interview. And, I wanted to go back to something that I should also say you referenced the sandsemic or the shortage of workers, right? There's some compounding factors that are really going to hit today's conversation. They're going to hit it home with some important points. But I want to go back to something that you said about, not shifting from calling them patients to customers. And I think that that's an extremely important part of this conversation because environmental services is a support service, right? It's not a revenue generating service. And there are lots of places in the hospital where they have these support services. And I will say traditionally, they're the ones that get their budgets cut. And, when we shift from patient to customer, there's something else that happens. If you were to start talking in the hospital about the patient experience, but change that to the customer experience, all of a sudden, these support services take on a relationship, as you said, to the dollars, to the finances. And there's a reason for that. We're going to talk about HCAP scores. But right before we do that, I want to talk about some challenges because these environmental services workers are in every nook and cranny of the hospital. They're in patient rooms, and they're not typically seen as part of the patient care team, which would assume patient experience. And it's all a cognitive dissonance when you really look at how hospitals are reimbursed today. So let's change it. Let's say they're part of the customer care team. Let's say that they're part of the customer experience. And let's talk about some of the common challenges that just traditionally exist in this workforce population that would put a challenge to the customer experience.
Yeah, Justin, what comes immediately to mind is that a lot of these workers in environmental services, English isn't their first language. And so, they come from diverse cultures and languages. And one hospital in Seattle with, like 300 employees in the environmental services department, they had like 17 different countries, nationalities represented in that work group. And so, sometimes those cultures clash I personally, at my last hospital that I worked at, we hired a lot here in St. Louis. There are a lot of Bosnians that have relocated to this country, and they came to the Midwest because of the low cost of living, and there were a lot of small manufacturing companies looking for workers to work machine presses and what have you. And so it was a low skill job, and they got paid well. But these were all the ones that worked for the hospital were all the Muslims who were being ethnically cleansed in Bosnia, a lot of them from Sarajevo, who saw a lot of these atrocities. But we also hired a lady, and we didn't know at the time that she was Serbian. And so it was a clash of those two cultures, even though it was years before, but the memories were too bad to overcome, and the Serbian lady wound up quitting because I don't know if she was being bullied or what it was. So sometimes you have those cultures that clash in the department, and it's some underlying things that you don't even know about. But we have people from language situations, and the other thing is that they may not have graduated from high school, but it doesn't mean that they're not intelligent. But we have to work with what we have. And so wherever I look to hire someone, I'm looking for someone who can talk to people. So wherever I'm out at a restaurant and I get good service, I say, would you like to work in a hospital and make an impact on people's lives instead of serving hamburgers and fries or whatever? So if they have...
Yeah, really giving them a sense of true mission, right? Like taking a talent that they already have and then putting a real mission behind it. And, you mentioned all those common challenges that are like cultural, language barriers, and there's a socioeconomic piece that you didn't necessarily mention. But I love how you're trying to build a good team through that. But another theme in here and an area of opportunity really lies into training. And so I had to jump in there and ask you this question about the management staff. If you already know, as you mentioned, Seattle Children's, 17 different nationalities and cultures all coming together, what kind of training do managers in environmental services get to help manage, those what could be multicultural conflicts, et cetera? Because I got to think that there's no other workforce with such diversity. And I think I know what you're going to tell me about the training for management that's just going to leave this as mind blown, wide open opportunity.
Right. And I think that this is an opportunity that we in the service business miss, and especially in EVS departments, hospital EVS, is that some of the third-party contract services, say Crothall or Aramark or Sodexo, they recruit college graduates. And what I like to say is that we that aren't those third-party companies, we should be there at career day and meet with these young college people and say that, how would you like to eventually have your own department in a hospital where you're actually saving lives? And you don't have to have a nursing degree or whatever, but you can come to work and you can make a real impact on a patient experience by leading those people who need solid leadership. And so we can teach people how to do the task, but we need people who are leaders. And, by the way, you can make $60,000 a year. And so you can have an important job role. You can make better money than you'll make at Verizon just because you get a free cell phone or whatever, working at Verizon with your college degree. But you can make a real difference in the world by doing your job and leading others to do their job, because everyone, people don't quit jobs. They quit bosses. And
oh yeah.
And so we want that to be solid leadership, and you have to enter into that experience and evolve with the team that you're leading. But ultimately, you're going to wind up leading people to do an exemplary job. And you mentioned earlier about fitting in with the patient care team. And that is one of the roles of leaders in an EVS, is to make sure that we are well integrated into the patient care team so that they see us as an asset, and that when the nurse is standing there talking to the patient, they turn to the housekeeper just came in and say, Linda's been with the hospital for 20 years. Can you believe that? And she cleans patient rooms every day. I know how I hate to clean toilets, but she cleans 25 of them a day. And, she does it with a smile on her face. And so you're introducing her to the patient as an important part of the patient care team.
Well, so we're going to tie this training piece to the shortage in jobs, and then I'm going to combine that with a hot topic for Larry that I really want to dive into, is antibiotic resistance, and get a little bit back into, virus conversation, et cetera, as it's been so prevalent. But I really want to finish this piece on becoming part of the customer experience and tied to revenue. And I really want to make a nice, strong connection here, which is this workforce has a direct impact on reimbursement. It does impact revenue, and so many people do not understand this. And I really want to bring up HCAP scores, which you can define for us, and then also the impact on infection rates and readmissions, because I'll kind of fill in that one for everybody. With the Accountable Care Act that came in, in the time frame of 2010, so, over the last decade or so, reimbursement changed that if a patient comes back into a hospital after a procedure, that the hospital has to pay for that care. It's basically saying that we are accountable for delivering quality care, and environmental services has a direct impact on that, because patients can get fomite infections, etc. And if they go home, the hospital has to pay the bill. It used to be if we didn't do a great job and the patient came back in, the hospital just got to make more money cleaning it up. And that's not how it is anymore. So can you talk about that, maybe add on to that, and then really tie it directly to the customer experience as it relates to HCAP scores?
Sure. A couple things that you said there, Justin, resonate with me. And one is that the HCAPs, this is the Medicare and Medicaid, CMS, the Centers for Medicare and Medicaid, and they're the ones who pay for those services in a hospital, Medicare and Medicaid patients. So for a lot of hospitals, depending on the patient mix, your reimbursement from CMS could be 80% of your revenue or higher. And so
and CMS, real quick, CMS stands for Center for Medicare Services?
Medicare and Medicaid.
Medicaid services.
Yeah. So it's quite a large swath of the patient population in most hospitals. And, the average age may be in their 70s, mid-70s. And HCAPS ties in with CMS. And HCAPS is the patient satisfaction surveys that people get. And hospitals have to survey their patients and measure their patient experience. And one of the questions on that survey is, during your stay, how often was your room and your restroom kept clean? And you want them to say always. Always scores, right now in the country, the average always score, because they only measure the top box scores, usually are always. That score is somewhere, for that question, is somewhere around 72%. If you fall below that 72%, then you could be in jeopardy of, depending on how far you fall, because it's usually an indicator of other patient experience between nursing and doctors and all that. But anyway, it is an important question that patients do get surveyed on. So that ties back to the reimbursement, but now patients are becoming more savvy and going to the websites, a Hospital Compare, a CMS website, Hospital Compare, and they can compare other hospitals in their area for scores like cleanliness. They're educated consumers, and then they make choices about where they want to get their care. And so it's important that we do well when it comes to that question. As far as the other one, like you said, the readmission rate, if they're readmitted within 30 days of their discharge and it's for an infection that they got while hospitalized, the hospital has to eat that cost. And I think insurance companies are also catching on to that. Companies are catching on to it. And if CMS can get away with it, then we will too. So when they negotiate those contracts with hospitals, they may use those same standards and say, we're not going to pay for it. If it's something that they got while in your care, then that's on you.
So that's something that's developing, as far as setting new standards in terms of reimbursement, right? But also in the customer experience and the customer empowerment, they're able to take on a new standard as the customer based on available information. But I really want to take us to, those are two critical changes that are going on. But there's another one that I think doesn't get nearly enough press, and it's a hot button for Larry. And it actually is something that Larry and I, when we very first met, it was central to a lot of our conversations when we began to get to know each other. And it's this concept of antibiotic resistance, right? We had this threat with COVID, and that's a viral threat, an airborne viral threat. I'm sure Larry will have something to say about that as well. But also antibiotic resistance is becoming a huge, huge concern. And I don't think that the general public really understands when you described the pre-World War II era and the infections, that we might actually be going backwards in time in terms of our susceptibility on that. Boy, people have got to take notice. They got to stand up and take notice. And Larry, I know you want to talk about that. So can you talk about what your concerns are around antibiotic resistance and really tie that into this general conversation that we're having with Darrel?
I think, Justin, that when Darrel was talking earlier about the antibiotic resistant bacteria, the VRE, the C. diff, we have reports and data that indicate to us that a patient that is in that room, if it becomes contaminated because maybe the patient is shedding this antibiotic resistant microorganism, if that room's environmental surfaces, doorknobs, commode, bed railing, if they become contaminated with that patient's MDROs, multi-drug resistant organisms, we might call some of them superbugs, that there's an increased likelihood that a subsequent patient who would then be treated in that same room and then be exposed to those MDROs, that there's an increased risk of that subsequent patient becoming infected. There are a number of reports that talk about this, and the rate at which, or the likelihood at which that subsequent patient might be infected depends in part on a number of factors, one of which is the specific MDRO, the specific organism. So I think Darrel's focusing very well. If we can shift a little bit from the problem of the MDRO, is we can move toward how to mitigate it. And I think that's when the environmental surfaces, the use of bleach, the use of thorough cleaning techniques can kind of get us around a little bit of the antibiotic resistant problem in a way by destroying the bacteria at its source, where it is residing. Darrel, does this make sense? Do you have anything that you could add to that in terms of the importance of the environmental cleaning to rid us to some degree or mitigate our concern about antibiotics not being able to destroy some of these emerging and morphing organisms that are finding ways and enzymes to get around the antibiotic that might otherwise kill them?
Yeah, Larry, that's a very good question. And I say in my book that, with some of these organisms surviving on dry surfaces undisturbed can live on that surface for 56 or more days. C. diff is about 6 months. And some of these other organisms can be as long as a year. And so it becomes a problem is that when those things get picked up on contact, with hands or gloves, and then changing a wound dressing on the patient, then so many hospitals emphasize hand hygiene, but we still find that fewer than 40% of the clinicians in the hospital are doing proper hand hygiene, whether that is washing with soap and water for 20 seconds with friction, or if it's using hand sanitizers. But those alcohol-based hand sanitizers are not effective against C. diff, the spores, norovirus. it's not effective against that either. So a lot of these organisms, not a lot, but these organisms are very resistant. Biofilm building up on the surface is another issue. You mentioned the surface, but if we don't disrupt that biofilm, just like the instruments going through sterile processing, if we don't disrupt that biofilm on those instruments, then the sterilization isn't going to be as effective. So without disturbing and removing that biofilm, which just a spray, what I call spray and pray. You spray a surface and you wipe it and you pray that you killed the organisms on there. That doesn't disrupt the biofilm. Things like actual friction, microfiber cloths, that act as a scraper and collect the soil on the surface. And I believe that if we do a better job of removing the soil, then if we can remove 99.9% of the soil from a surface, then with the soil that gets collected in the microfiber goes the bad guys. And then the disinfectant that's applied to the surface has a much better chance, because these disinfectants are, whenever they're registered by the EPA, they're being registered in the presence of 5% soil. You cannot even see 5% soil. And you mentioned C. diff, there's enough infective material in a pinhead size fecal matter on a surface to infect a patient. And no one's looking for those pinhead size pieces of fecal matter. And so we need to get rid of the term we pre-clean wherever visibly soiled. We just need to assume that we need to pre-clean a surface. EPA and CDC both say that disinfectant should only be applied to a pre-cleaned surface. But we've got these one-step disinfectants that people are depending on. Rather than removing the little boogers, we're hoping to kill them with the disinfectants. And we need to do a better job of removing the soil. But you mentioned subsequent admissions to that room where a C. diff patient was, or someone with one of these MDROs, and your chances of getting a C. diff infection are like twice as great if the previous patient in that room had C. diff. But now they're even saying, even if the patient was on antibiotics for an extended period of time, even though they didn't have C. diff, you could have organisms on that surface that are resistant to antibiotics and could be resistant to the cleaning process.
So, Darrel, this brings us to a really good point where you said earlier again about clean surfaces save lives. And what that then means for us, of course, is that a contaminated surface can pose an infection risk. A contaminated surface can harm someone. And I'm hearing that hand washing and environmental cleaning can be as important as the development of antibiotics to destroy MDROs, to destroy these antibiotic-resistant bugs. Let's try to kill them before they ever infect the patient. Let's get rid of them in the environment. But this brings us then to a controversial issue we've been talking about the last year with COVID. And we saw about a year ago there were the ambulance departments, the high schools, school districts were considering buying some devices that might cost upwards of $100,000 to maybe emit a vapor of hydrogen peroxide or emit some type of a spray of bleach or maybe even a blast of an aerosol fog in order to destroy COVID, which might rest on a environmental surface, maybe on a desk or in a gymnasium or in a locker room. And there was a paper that came out about the same time as this. This is kind of, let's go back to March and April of 2020 when COVID was the center focus for all of us. And the CDC published a report where they went into some cruise ships. And this was a real concern because, of course, people disembarking from cruise ships can take a infectious organism, a virus, and transmit it throughout an entire community. And this can become, obviously, the beginning stages of a pandemic. And the CDC reported in this MMWR in March 27th of 2020 that they sampled the surfaces of these cruise ships, and they found on the surfaces in the cabins the presence of what could lead to a COVID infection. That is, the virus's SARS-CoV-2 RNA. So can you discuss a little bit how it seems now that the CDC is saying that the environmental surfaces do not transmit COVID, that there's less than a 1 in 10,000 chance of being infected from an environmental surface with COVID. Can you give us a little historical sense about how we kind of went from COVID on grocery bags, COVID on cabin surfaces, and COVID in the environment and at the supermarket or any surface that we touch that it could infect and harm us, to where we now get the sense that it's less than 1 in 10,000? How did we get that wrong? Was there ever a precedent for coronaviruses on contaminated surfaces to infect us or not? Can you give us a little brief history and some counsel on that?
That's a very good question, and I've wrestled with that because part of what I do, too, is I educate people online. Business partner of mine down in Orlando, he and I do about an 8-hour discussion of the importance of cleaning and disinfection. And we trained about 1,400 people last year because of this hypersensitivity to the news that it's transmitted on these surfaces. And just in the past 2 months, that has dried up to like 2 people a month. We were doing 50 and 60 people a month. And so did we get something wrong? Where did we go from where we were, where there was the hysteria about COVID on the surfaces infecting us, to now to the sense that it's really droplet and aerosol, not surfaces? Did we not have precedent for this? How did we get this wrong? Well, coronaviruses have been around for eons, and this was a novel virus, and so I think some of the extra caution was the novel part of this, and we felt like we didn't know enough about it, and it wasn't exactly like other coronaviruses, like MERS and SARS, and so those have pretty much gone away. The SARS and the MERS is still out there, but these zoonotic kinds of coronaviruses can be very tricky. And so the messages out of China early on were very cryptic. We were learning as we went, and out of extra caution, even though these things could be cultured from environmental surfaces, there was never enough data to say that it was an infective dose from a surface. So, meaning that if we identify RNA on a surface, that means the virus was there, but does not mean the virus can infect us. Correct. It wasn't enough of a dose. And what I found out is you can take all the coronavirus in the world and you can put it in a soda can, is what I've read. Viruses are very small, very tiny. It's usually not transmitted on surfaces. But while these patients were in ICUs on ventilators for months, weeks or months, and on heavy antibiotics and antivirals, and they were trying to save patients, it really set it up for C. diff and some of these other things to go unnoticed, because these heavy doses of antibiotics were just setting the patients up for other things that could turn into be one of these MDROs that gets left behind. And, there's numerous studies that have shown that even after a thorough cleaning of a discharged patient's room, that after the cleaning is done in that room, there's still 40 to 50% of the cultured surfaces show the organism still being there. So what you say about patient rooms, and what I say is it's a patient room lottery. You don't know what the person, 2 rooms look perfectly clean, but if you're admitted to a room where the patient was on heavy antibiotics for a period of time or had C. diff, your chances of getting that organism are like doubled.
So I want to tie this together and really make our final point as we wrap up the interview. But you just alluded to something about antibiotic resistance by the fact that, hey, while we were not so sure what we were doing and we're pumping this, we're actually contributing to a much larger problem that exists on the periphery of our daily focus during the pandemic. And, I know that really led to you to write this book, Infection Prevention for Dummies. And we've alluded to it a few times. I'd really like for you to tell your story about why you wrote that book and why you believe so passionately that this message really needs to get out there around antibiotic resistance.
Yeah, it was in 2007. My daughter-in-law at the time was about 37 years old, She was very physically fit. She was actually training for Iron Woman competition. There's an Iron Woman competition. It's Iron Man competitions, and women have to compete with men. But she was spending a lot of time in a workout facility, lifting weights and what have you, and she got an infection in her hand between her thumb and her first finger. As it turns out, it was MRSA, community-acquired MRSA that she got from this health facility or workout facility. It became a bloodstream infection, and within about 8 weeks, she was dead and left my son with 3 kids, and the youngest was 16 months old at the time. And so it has had an impact on our family forever. So the message is, Larry mentioned it earlier, about schools and other areas where these multi-drug resistant organisms are out there, because not everyone with MRSA is in a hospital. They get better and they go home and they're out there shopping where you shop and, working out in these facilities. So MRSA can be cultured from many surfaces, but I wrote this book because someone dropped the ball, literally, on cleaning and disinfecting surfaces in a gym. So it's one of those personal stories that I like to tell.
I'm sorry to hear that.
Yeah.
But I appreciate your sharing it with us.
Yeah, but that's where my passion comes from for better, more thorough cleaning to save lives.
It's very generous of you to share that. When I alluded to the sense of mission earlier, I was really speaking to the fact that you had a strong sense of mission, and you shared that with me, but I did not share it with Larry. I wanted Larry to hear your story at the same time that maybe our audience is hearing it. But I think it's an extremely important message. And so, at the end of the day, the takeaway from your life's work and your life's literally outside of work experience is that environmental services is far more important than it's been given credit. In many cases, it's not acknowledged as a profession. And Darrel, I just want you to hit this one home for us and say what needs to be done, not only in the healthcare environment, but in the general community. What needs to change for environmental services to truly be recognized and acknowledged not only as a profession, but as critical to the public health?
Well, during the pandemic, when hospitals were full, and I saw it time and time again how the clinical staff called those environmental services workers heroes, and they really are. And during that time that they showed up for work every day and went into some of these. And I know people that, departments, environmental services departments that didn't have PPE early on, just like there was such a shortage for the clinical staff. Well, pretty low down on the food chain is environmental services workers that were going into those rooms. And one hospital told the EVS director to go to Walmart and buy raincoats for her staff that they could be disinfected, instead of the isolation gowns, because they didn't have them. To wear these gloves, that could be washed, like Playtex living gloves that you wash your dishes with, so that they could. So early on, it was very difficult for those people to show up every day and not believe that they're taking something home to their families, because like Larry said early on, we were still finding our way through this crisis. And so my message is that they are heroes, and we need to not only call them that, but we need to start paying them like they're important. They're some of the lowest, they are the lowest paid department in the hospital. And Justin, you said earlier that when budget cuts come, a lot of times environmental services is the ones that they turn to and say we need to cut staff.
And yet your point is that infection control starts with them and works its way up.
So instead of looking as a commodity that we should get cheaper than, like we're buying toilet paper or something, we're looking for the lowest price. We need to stop looking at cleaning and disinfection as a commodity that we want to get a lower price on, and we need to do better at educating them, training them, paying them like they're important, and begin certifying them to a certain level of knowledge. If they were stuffing hamburgers in the drive-thru 2 weeks ago and now they're going to clean the ORs, they need to be certified to a certain level of knowledge about how bugs get transmitted from a surface to patients or to staff. And so we need to do a better job of educating, training, paying, and recognizing them as the professionals that they are.
Well said.
You nailed it, Darrel. Great interview. Thank you. That was Darrel Hicks, owner and principal of Safe Clean and Disinfected Environmental Services, with just a really incredible story to tell, and one that, I think we all know it's personal experiences like that, really grab the attention and drive a mission like Darrel's home. What's so interesting about it is Darrel was already in this field for quite some time. So for a personal experience to hit his work life and matter of expertise, is really very odd. It's no wonder that he wrote this Infection Prevention for Dummies book. And I wanted to add one thing as we were talking about, certification and pay scale reevaluation. Larry, I think one thing that may happen here, because we talked about the worker shortage, and it's a term that I've been hearing a lot lately, is around the SANSdemic. And so, yes, with just workers' compensation benefits and everything that happened with the pandemic, that really highlighted a worker shortage. But this is not a short-term thing. All of the predictors out there say that with the largest baby boomer population moving into retirement, plus they're wealthy and their kids are living off of their wealth to a degree, and younger people are focusing on quality of life. So even if we were having a one-to-one into the work environment, they're not necessarily working full-time hours anymore. And many of them are staying home because they've had this huge debt of college debt, and they're still living with their parents up until 30. And all of this is leading to what is going to be a shortage of workers, or a SANSdemic, for a very long period of time. And I think that will ultimately correct pay scales just by virtue of the classic supply and demand. If there are less people to do these jobs, you will have to incent them better to have them do these jobs. But there isn't an organization out there that isn't going to incent better without getting something like certifications and like better training and like better qualifications, or maybe a degree. And I think that shouldn't necessarily be required. I like the direction of certification here and becoming, maybe formalizing a competency that's standardized, that you're an expert in this industry. But the other thing I talked about, Larry, that, I kind of want to take also a little bit personal just for you and me is, you and I have known each other for several years now, but in our early conversations, I think one thing that just really was predominant in our conversations was this antibiotic resistance conversation. And a concept that you introduced me to that really ties very much into the naming of this podcast was this concept that antibiotic resistance is something that it could be a tidal wave issue. And it's almost like a train speeding down the tracks towards a brick wall. The tunnel has been sealed over. And there are many instances where we have transmitted bacteria, but just because that's transmitted doesn't mean that through the use of prophylactic antibiotics or taking antibiotics prior to a procedure or being treated with antibiotics afterwards, that it would actually mask some of the infections. And so there are many transmissions that do not result in infections. And so a lot of times, we hear about infection prevention and we hear about, infection control. And that's really where we got this name, is this concept that the real meat on this bone that people have yet to realize is actually transmissions.
And that's where it comes to the mitigation. A physician might argue, well, I don't care if I'm transmitting something inadvertently or it's one of the side effects of a procedure where the benefits so clearly outweigh the risks. One might say, well, I'm concerned about the infection. If the patient goes home asymptomatic because of a transmission, who really cares? There's something to be said for that, but I think as the engineer starts to address the mitigations, the corrective actions to prevent these events, this is where you want to know what the transmission rate is, even more than the infection rate, because you could have millions of transmissions and zero infections and walk away saying you have no problem when indeed you do have a problem and indeed corrective actions are warranted. So I think we need to keep both transmission and infection in our vision and in our focus, and that both are important, and in some ways transmissions are more important. That is the rate of transmissions, and in some cases, from a treatment standpoint, maybe the rate of infections is more important. So they're both very important issues that each are necessary for us to address to improve hygiene, to improve the quality of care.
Well, Larry, I'll tell you, it's interviews like today's that really fuel, my passion for this project that we're working on together. And I'm so glad that you're on this journey with me.
It's a pleasure. And I just want to end with my thoughts in that Darrel was talking about how patients diagnosed with COVID and being treated in hospitals with COVID were very often simultaneously and concomitantly given antibiotics because it made sense. But I'm wondering whether this, in the next phase, as the rate of COVID infections and transmissions drop, do we start seeing some type of a secondary effect, almost, let's hope, on a much lower scale, of some type of a super bug, not so much pandemic, but epidemic?
All right. Well, that's going to do it for this week's show, as that was kind of an ominous ending, Larry, and I actually really appreciated it. But as a reminder, you can help support us by subscribing to Transmission Control on Apple, Amazon, or Google Podcasts, Stitcher, iHeartRadio, Spotify, or your favorite podcast application. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.